Alarms are blaring, the monitor is flashing absolute chaos. So what's your very first move? Welcome to the ultimate cardiac blueprint. In this explainer, we're going to crack the code on cardiovascular emergencies so you can tackle your MS2 exams with absolute confidence. Listen, if you're a nursing student, you already know that cardiac function, rhythms, and perfusion are some of the most heavily tested and honestly the most intimidating topics you're going to face. But today, we're breaking the whole thing down. We're not just reading textbook definitions here. We're going to chunk the information, use some solid memory tricks, and train your brain to recognize clinical patterns exactly the way the NCLEX wants you to see them. Let's get right into it. Imagine you're right there on the floor. All the bells and whistles are going off, and we really need to know, are you assessing the machine or are you assessing your patient first? This is a classic NCLEX trap, and it catches so many students off guard. When a wild, chaotic rhythm pops up on the screen, your gut instinct might be to just slam a medication or start compressions, based entirely on those squiggly lines. But you have to pause and think. The golden rule of nursing prioritization is that we treat the patient, not the monitor. Your absolute first move is to assess the client. Are they responsive? Do they even have a pulse? An artifact from a loose lead can look exactly like a lethal arrhythmia, so always verify hemodynamic stability at the bedside before you do anything else. When you see a rhythm that looks somewhat organized suddenly drop off a cliff into absolute chaos, you know you're in trouble. Ventricular fibrillation means the ventricles are literally just quivering. There is zero cardiac output happening, which means absolutely no blood is perfusing the vital organs. Recognizing this pattern instantly tells you the patient is in cardiac arrest. There's no time to second guess, no time to wait. This requires immediate CPR and defibrillation. Burning visual memory anchors like this transition point into your brain is absolutely crucial for your exams because rapid pattern recognition here is, quite literally, a matter of life and death. Your clinical judgment must always prioritize hemodynamic stability and patient safety above all else, period. Every single cardiac question you encounter is basically asking you one core thing. Is this patient safe, and are their brain and body getting enough oxygenated blood? If the answer is no, your nursing interventions have to be rapid and highly targeted. So when you're studying, don't just memorize a laundry list of symptoms. Constantly ask yourself, what would the nurse do first? Usually it comes down to securing the airway, applying oxygen, getting a focused assessment, and making sure you have continuous ECG and vital sign monitoring hooked up. To make those rapid-fire decisions, you've got to chunk hemodynamics into bite-sized, digestible pieces. Preload is the end diastolic stretch, or the filling pressure. Afterload is the massive resistance the heart has to push against to eject that blood. Let's use a quick memory trick to lock this in. Think of preload as a pool of blood filling up the heart. It's the stretching of those cardiac muscle fibers at the very end of diastole when the ventricles are totally full. Now think of afterload as arterial resistance, the sheer force the heart must push against to pop open that aortic valve. If a patient is fluid overloaded, their preload is huge. If they have severe hypertension, their afterload is sky high, which forces that heart to work incredibly hard just to keep up. If you take nothing else away from this explainer, lock this into your brain. Cardiac output dictates perfusion to vital organs, and it's entirely dependent on multiplying your heart rate by your stroke volume. Stroke volume is simply the amount of blood pumped out during the ejection phase. So why does this specific formula matter so much for the NCLEX? Because it explains almost every single cardiac symptom. Think about it. If your patient's heart rate suddenly shoots up to 180 beats per minute, the ventricles just do not have time to fill with blood. That means stroke volume drops, and therefore cardiac output absolutely plummets. Suddenly, your patient is dizzy, they're severely short of breath, and they've got crushing chest pain because their vital organs are actively starving for oxygen. It's an incredibly delicate balance maintained by our autonomic nervous system and varoreflexes. So how does that heart rate suddenly shoot up to 180 anyway? Well, it all comes back to the heart's intrinsic electrical wiring. It all starts with the SA node, which acts as our body's primary built-in pacemaker. It fires automatically at a perfect rate of 60 to 100 beats per minute. The SA node in the right atrium fires off the signal, giving us our P wave, or atrial depolarization. That signal then travels down to the AV node, which actually slows it down just enough to let the ventricles fill up with blood before it shoots down the bundle branches to contract the ventricles, giving us the QRS complex. Truly understanding this normal pathway is exactly how we identify when things go completely off the rails. When you see really fast and narrow QRS complexes where you can barely even spot a P wave because it's completely buried in the sheer speed of the previous beat, you are looking at supraventricular tachycardia, or SVT. Tying this back to our perfusion formula from earlier, when the heart is racing this fast, stroke volume just crashes. So what's your primary nursing priority right here? You have to assess the client's tolerance. Are they stable or are they unstable? If they're unstable and having near syncope or chest pain, you are prepping for immediate interventions. We're talking administering adenosine or getting ready for synchronized cardioversion to physically reset that electrical pathway. Now contrast that with a baseline that's a total mess. It's not a smooth, clean line, and there are absolutely no distinct, uniform P waves. The atria are essentially just quivering up there, sending a ton of disorganized, chaotic signals down to the AV node. Because of that, the QRS complexes are completely irregular, just marching out at totally random intervals. This is atrial fibrillation, and it is a massive clinical cue. When the atria quiver instead of giving a nice, strong squeeze, the blood just pools. And what happens when blood just sits around? It clots. And that brings us to a massive safety alert, because AFib lets blood pool and clot in the left atrium. Administering anticoagulants is absolutely vital. That means the very first thing the nurse must do is enforce strict bleeding precautions. This is a guaranteed test topic, for sure. We use tests like a transesophageal echocardiogram or a TEE to check for those clots. To stop a clot from breaking loose, traveling to the brain, and causing a massive stroke, these clients are put on medications like warfarin or heparin. Instantly, as the nurse, your priority shifts to safety. We're talking soft bristle toothbrushes, electric razors only, and super aggressive fall prevention, because even a minor bump could turn into a major, life-threatening hemorrhage. Now, whether it's from a birth defect or a history of IV drug use, when the heart's valves get damaged by pooling blood or infection, the whole pump loses its efficiency. The heart has to work way harder, and eventually, it begins to fail. We have to systematically gather our cues. Is the patient severely fatigued? Do they have dyspnea or orthopnea? Do you hear altered heart sounds, like a murmur? Once you recognize those cues, your action plan has to revolve around safe oxygen use, strict dietary teaching regarding sodium intake, and ensuring absolute medication compliance to ease the massive workload on that struggling heart. You've got to be on high alert for worsening fluid overload, because an inability to perform daily activities or a sudden weight spike requires rapid nursing action. And here's your core NCLEX priority: daily weights. It is the single most reliable indicator of fluid volume status. It is way more accurate than tracking intake and output logs. A sudden 3-pound overnight weight gain is not from a heavy dinner, right? That is pure fluid backing up into the lungs. That fluid causes rales or crackles, and it settles down in the legs as peripheral edema, which severely limits the patient's functional ability. Let's pause and think about a classic clinical trap. Your heart failure client gains weight and reports they just can't do their normal daily activities. What do you, as the nurse, do first? Now, a lot of students will instinctively jump straight to notify the healthcare provider. But remember, when you call, the provider's going to ask you for the clinical picture. Your first action is always to assess. You need to auscultate their lung sounds for those crackles. Check their oxygen saturation. Assess exactly how bad that peripheral edema is. You absolutely must gather and analyze the cues to determine if their airway and breathing are compromised before you even think about picking up that phone. Okay, let's do a rapid-fire pharmacology recap. Let's lock in these 5 must-know cardiac medications. Whether you're slowing the heart rate, increasing contractility, or chemically converting a tricky rhythm, these are your primary pharmacological tools. Amiodarone is your heavy-hitting antiarrhythmic for the scary stuff, like VFib and VTEC. Atropine, think accelerates, we push this to speed up a symptomatic bradycardia. Metoprolol is a beta blocker, think brakes. It slows the heart down and decreases the overall workload. Digoxin gives the heart a deep and incredibly forceful contraction, but it requires really close monitoring for toxicity. And finally, diltiazem is a calcium channel blocker that calms the heart rate, which is especially useful when dealing with a rapid atrial fibrillation. Before we wrap up this explainer, I want to leave you with a crucial thought. Cardiovascular emergencies are terrifying. They're scary for the client experiencing the chest pain or the crazy new arrhythmia, and they're definitely stressful for you as the nurse. But your calm, systematic approach, relying on the pattern recognition and prioritization we've just covered, is exactly what will save lives and bring the anxiety in that room way down. You know how to manage the arrhythmias and the fluid overload now, but what happens when the heart muscle itself begins to die? In our next breakdown, we're going to tackle the immediate interventions for a myocardial infarction. Until then, trust your knowledge, treat the patient in front of you, and stay calm. You've got this.